Thank you. Thanks, Mary. That's very nice. I appreciate you. Yeah, so like Mary said, my name is Kayla and I own a very small private practice in Fremont, Nebraska, where we do intensive outpatient and individual therapy evaluations. I run a DBT group that's kind of fun, and we have like an aftercare alumni group as well. So we do a lot of things. Substance use, I always say, is like my specialty. Um, and yeah, so I'm going to talk about IOP today. So I thought I would start off with like who I am. As Mary touched on, I kind of have like a interesting story. Um, I am not a professional speaker by any means, so you'll have to bear with me on that. I will probably say like 3,000 times. I apologize. Um, But I always start my groups with my patients having them share like who they are besides an addict and an alcoholic. So I thought only fair that I do the same thing as I have them do. So besides an alcoholic and an addict that is in recovery, I am a mother to eight beautiful girls. Um, my husband and I blended a family together, and it is probably my biggest blessing um, and achievement in my life, I would say by far. What I'm most proud of is our family. It's pretty amazing. I am also a grandma, which is super cool. I have a 4-year-old grandson and a 5-month-old grandson. They are like the greatest joy in my life that I never knew I needed or that it existed. So that is really cool. I have a dog and a cat, because we didn't have enough humans to take care of, so we thought we'd get more things we needed to take care of. Um, and yeah, I think I
Yes.
like to bake and travel and do normal people things. Um, I really enjoy that. My kids are eating all the carbs now because I learned all about bread making. It's like the funnest thing in the world. Um, I have 12 years of recovery as of July 23rd. I got sober in 2014. My drug of choice was meth, but really I struggled with everything that you could imagine. Um, at the end of the journey, it was a pretty dark place. So it took me a long time to find my way out. Like Mary had said in 2011, I knew that I needed to change the way that I was living. I just couldn't figure out how to actually do that. Um, so it took me a long time to find the way out. And so after I got sober, I decided I was going to go to school and enter a field of helping people. I thought about becoming a nurse, but I'm not a big fan of body fluids, so that kind of turned that road into I was going to go the mental health route, and I got my PlayDoc. I went back to school and got my associates and got a PlayDoc from Metro. And then I went on to get a bachelor's in social work and a master's in social work. And just for funsies, got a master's in public administration as well. So today I have a LADAC. I am a licensed independent mental health practitioner and a licensed clinical social worker. So lots of fun letters to write after my really long last name, just like you just write forever. Um, but I feel after I got my first license, I started working in the field in substance use, and I always thought I would work in a residential treatment center and work with people that were like brand new in sobriety. And my first job ended up being in an outpatient office, and I fell in love with it. I was like, oh my gosh, we can like help people before they lose everything, which I never even considered until I started working there. And so as I was working there throughout the years, I was like, we absolutely can start to address substance use disorders before people find themselves homeless or before people lose their jobs and their families and all of the things that people lose in addiction. So that's why I love outpatient. That's why I wanted to continue working in outpatient. That's why I wanted to open my own little place and start this. And I'm pretty passionate about it because I've been doing this for a really long time now. I'm going on about a decade in the field. So I've seen just about everything you can see at this point in the game, but it's a really cool gig, I always say. You get to watch people change, and it's probably one of the coolest things that people could do. So today I kind of want to just go over like the different levels of care because that's the best way to introduce what IOP is. We'll talk about what IOP is. I kind of outlined the program that I have, which is similar to most programs. They're all a little bit different, but and when would be the best time to refer to IOP? And then I thought I would touch on like MAT and IOP as well. And to start off with, the fun stuff, I put a boring looking dog on there because sometimes statistics can be boring. Um, so the idea that 1 in 6, which is like 49 million people in America, meet criteria for a substance use disorder. There's also statistics out there that like only 10% of those people will ever actually receive treatment. So I think that that's also an avenue that outpatient is able to help with, is to help increase that number, because accessibility to outpatient is usually a lot easier than accessibility to maybe a residential treatment. Um, and I think that that's important for you guys to know because the majority of people are probably going to see their primary care provider or a med provider or somebody along those lines long before they ever even think of the idea of going to treatment. Because I believe that kind of with stigma and in the world, a lot of people, when they think about treatment, they think about a 30-day residential treatment, which is unrealistic to some people. They're like, well, how can I go away for 30 days? Because I have a job and you can't just leave your job for 30 days. So in like 2000, they did this huge study where they found out that most of the people that were going to their primary care provider, were not being screened for substance use disorders. So they started this whole big process into getting a lot of screening done. So today we see a lot of screening for substance use disorders, kind of the questions that are asked on those surveys and the paperwork that people fill out when they come in, like how many drinks do you have a week, that kind of stuff. So that was, I think that really helps to start to identify people who need treatment sooner. And so that is where IOP can even step in as a great option because we can catch people earlier. We can catch them before they go all the way through the addiction cycle and hit, the rock bottom that everybody talks about. I feel like when I first entered the field, or even when I entered recovery myself, everybody was like, you have to hit rock bottom, you have to hit rock bottom. But what I have learned is that rock bottom is a never ending level. Like it can go lower and lower and lower and lower until eventually death. So the idea of rock bottom, I think, could be adjusted in people's heads a little bit. The idea that like you don't have to lose everything in order to get sober. You don't have to lose everything in order to change your life. Um, so I always kind of challenge that idea as well, that we don't necessarily have to hit, the stereotypical rock bottom before we start to change our lives. And it's just better on this side. Um, so like I talked about a little bit, why I think this might be important for you guys is that most people they don't just suddenly one day decide and show up in a treatment center. Like they spend months or sometimes years having interactions with healthcare providers, mental health providers, all sorts of different providers, typically before they even take their first steps into a treatment center, whether that be an outpatient one or an inpatient one. Why it matters to me, I've learned that addiction is totally treatable, that we can step in and we can help people. And I think that treatment honestly works best if they're referred before the crisis. If we can catch people before the biggest crisis, those big giant crises where, maybe CPS has stepped in and taken their kids out of the home, or they have legal charges. I think treatment works really well for individuals before they experience those things as well. And a lot of times those things are what push people into treatment, but I always like to emphasize that we can definitely offer treatment to people before they experience those types of things. So I made up a fake eye. ChatGPT is really cool if y'all haven't played with it at all. They made this picture. This guy. I was like, I need a fake person. He is, and I gave him like the details and they made that picture. So I thought that was really cool. So his name is Michael. He's 34 years old, retired military, currently works as an engineer. He's married, has one kid. Mental health, he reports that he is not sleeping well. He has nightmares, has a lot of the alert, being constantly alert. He's nervous, on edge. Um, Alcohol use has been increasing. Um, he is drinking nightly at this point. Um, and he started doing that after the birth of his child. He also started um, using meth on the weekends because on weekends he's drinking all day long and the meth helps balance that out. And it also gives him the energy to do the housework he needs to do around the house because he's always so tired because he's not sleeping well. Um, he doesn't have any arrests. He's never been in trouble. He's never had an overdose. He hasn't lost his job. Um, and I think this is probably the most common type of person that might walk into someone's office, someone who looks like their life is still together. Um, so I guess my question to you guys would be like, would you refer him to treatment today? Would you prescribe mat treatment? Like, how would you guys handle Michael? I don't know if anybody wants to answer. You don't have to if you don't want to.
Yeah, yeah, feel free to unmute and answer, or you can drop your thoughts in the chat. Um, any way is fine.
Is he ready for treatment? I would first assess that.
That's a great question too. That's like one of the most important questions. Yes. Let's say he's ambivalent. He's unsure. He doesn't even know what treatment is.
I guess I would start by sharing what treatment is and
Mhm.
what that looks like for him.
Absolutely. Good job, Carla. Yeah. We'll come back to Michael in a little bit as well. We'll kind of see if we change the way we feel about it or any of those kinds of things. Um, so I think that there's lots of opportunities for intervention and for people to step in and educate someone on what treatment is. Like I talked about earlier, most people think that treatment is a 30-day residential stay. If you talk to people who don't necessarily work in the field or who don't have experience with it, or they haven't had a family member go through the process or anything, most people believe that treatment is the 30-day residential stay. So there's lots of opportunities where we can start to step in and educate people on the different availability of treatment for people. So, definitely whenever somebody talks about daily use or having sleep problems, health problems, DUIs, those kinds of things. Even like binge drinking patterns are an important one to look at as well, because oftentimes people with binge use patterns have a harder time recognizing that it might be a problem in their life because they could say, oh, well, I can go weeks or months without using. But when they do, it like causes a lot of disruption and a lot of problems in their life. And I always think like the earlier the intervention, the better the outcome. And I don't think that Michael needs to lose his job or his marriage or, experience an overdose or any of those kinds of things in order to get the opportunity to go to treatment. So there are different levels of care and treatment, and that's kind of what I was talking about. There's the residential treatment, which is where somebody would go and live for, typically 30 days. Sometimes it's longer. It's 24/7 care. They have, usually a nursing staff on hand, a psychiatrist. They have a team of counselors, support staff, people there all day long to help educate and teach them. It usually comes with about 40 hours of programming a week. So kind of like a full-time job. And they get a lot of community support and they do, individual therapy, group therapy. Often there's usually a family aspect to residential programs. Residential programs can be a little bit more difficult to get into. One, they're kind of expensive. If it's a like private, insurance situation, they're definitely going to meet their deductible and their out-of-pocket max. A lot of residential centers will require an substance use evaluation to be done before they can get in. Some do, some don't. It just depends on the treatment center. Treatment centers that often accept Medicaid or do like region funding so they can offer free treatment, they usually have a wait list. So those are just kind of things to know about residential treatment. And it does make it just a little bit more difficult for people to get into figuring out those aspects of it. PHP is like the next lower level of care. It offers 20 hours. It can be more, but 20 is like the minimum hours of programming a week. So with PHP, people can live at home, or a sober living house or whatever. And they go to the treatment facility each day and receive their programming, and then they leave and they go home. So there's not a lot of PHP programs in Nebraska. I know that Valley Hope does one and North Point does one, and I want to say CHI has one. And there might be others that I'm not fully aware of. I know that Valley Hope and North Point typically only accept commercial insurance, so that is a barrier for people as well. If they don't have, your United Healthcare or your Blue Cross Blue Shield, if they're on Medicaid insurance, that can be it. But it does allow a lot of support for people who maybe are at that stage of addiction where they don't have a job and they can go to 20 hours of programming a week. Or maybe they work, the opposite shift of whenever programming is available for that. IOP is what I do. That is a minimum of 9 hours of programming a week. The way that mine works is we do programming on Mondays, Wednesdays, and Fridays from 6 to 9 p.m. There are other programs that offer different times of days. There is some that offer it during the daytime. There's some that offer it like midday, and then there's evening programs. So oftentimes, if a person is working, IOP is a good option because they can fit it in outside of their work schedule. And it allows them to work. It allows them to live at home. It allows them to take care of their daily responsibilities, all of those things. With IOP, usually individual therapy is offered. I don't force it on people. I say, if you would like an individual session, please see me after group and we will get you scheduled. And then I will schedule them. I have found that often forcing people into individual therapy is usually a painful process for them and for me, because they don't want to be there. So I offer it. I repeatedly offer it throughout the course of their IOP. IOP programs they how long they last varies. Sometimes it's 6 weeks, sometimes it's 8, sometimes it's 12. I think Valley Hope does a 36 session. I can't remember. But yeah, it varies in length from usually 6 to 12 weeks. Um, and then aftercare is the lower level. It's one time a week for 1 hour, typically in a group setting, but also individuals can be included in that. So it could be, more hours a week if they're doing individual therapy or like DBT groups or other things like that. Um, so that's kind of the levels of care. And as you go down in levels, the entry into that type of treatment tends to be easier to access. Whereas IOP, most places that offer IOP, they do their own evaluations, they do their own assessments. And that makes entry easier because they don't have to go get an evaluation somewhere and then take that evaluation and turn it into a treatment center in order to gain access into it. Any questions so far?
We had just a couple comments in the chat. I can go through, and it looks like maybe your question just dropped in. So we're just referring to that first case you mentioned. Just a couple of comments on there. Whether he knows or he needs help or not. So discussing that would be advisable.
Absolutely.
And then another person said, in my experience, when a person hasn't experienced any negative consequences, there's a lot of insight that their use isn't problematic yet.
Mhm.
We did hit a comment about level one OP, 2.5 hours of program per
Yes.
week. Yep.
Yes. Yeah. So there is a level 1.5. ACM just changed their levels recently. And they do a 2.5 hours. So usually they do some education in there as well, along with the group therapy. Um, Suzanne, if you know of a one that does a 2.5 hour one, you'll have to let me know the program, which place it is that is actually doing like a true 1.5, because I would love to
Um,
see what they're doing.
she said Lutheran Family Services has one.
Oh, okay. Perfect.
Yeah.
Yes. And then
Yeah, go ahead.
I'm reading them now. I
Yeah,
found them.
go for it.
For someone who is ambivalent, I find asking questions that probe into the insight of the adverse effects of their substance use, sleep, mood is a way to open up things a bit. This often takes multiple visits to register with the patient, however. Very true. Yes. Ambivalence, I mean, is definitely something. I mean, whenever we look at the stages of change, it starts with pre-contemplation, because people don't often have a ton of insight into their addiction or how problematic it could become, or even there's a lot of stigma around alcoholism and addiction and what that actually is, right? So oftentimes people think alcoholism and they think in order to be an alcoholic, you have to be drinking daily and you have to drink during the day, or you have to drink a certain amount, or there's just a lot of ideas of what alcoholism is. And it's usually around the amount or when people use. As I usually look at it, is it causing problems in your life and you're continuing to use despite those problems? That usually to me is like a big sign of, oh, there's something going on here and we should look at that. Patient seen in pain clinic, all UDS have come back positive for meth. Patient does not want to go to inpatient treatment, referred her to support groups, therapy, and ACT program. What else can I do with this patient? Patient has Medicaid. Absolutely. Stacy, I would refer her to like an IOP program and let the staff there kind of, they can determine as they work with them like whether IOP is appropriate. And I always say, like, if we can get someone in the door, right, and get a tiny bit of buy-in from them, if they need residential after I've had a week with them or something, then I have had a moment to kind of build a rapport with them, and then I might be able to get them to go to the residential treatment center. So oftentimes just even just referring them to, an outpatient substance use place can get them moving in the right place. I'm going to explain IOP right now. Okay, so IOP is according to the ASAM levels. I was going to go way deep into ASAM and I decided not to do that. So if you guys need another presentation on ASAMs, I can do that. But I was like, that's a whole presentation in and of itself. It's an ASAM level 2.1. I tried to keep it pretty broad because I was trying to stick to IOP today. Usually IOP is offered 3 days a week, typically. Now, some programs might do it a little bit differently because the defining thing of IOP is that it's 9 hours of programming a week, 10 if they do an individual session. So most places will set it up for 3 days a week for 3-hour sessions. Now, all programs, they kind of have freedom to figure out how they're going to get that 9 hours in. I do mine on Monday, Wednesday, and Friday from 6 to 9 because that works for me and works for my patients. Most of my patients, if they work during the day. So having an evening program is like perfect. But it varies. I worked for Valley Hope for a really long time and they offer IOP 5 days a week. They have a morning program and they have an evening program and they let the people choose which 3 days out of the 5 days they're going to attend. So like if they have their kids on Wednesday for visitation schedules, then they can go Monday, Tuesday, Friday if that works for them, which is a really cool thing that they're able to do. So it's a minimum of 9 hours a week. It offers group therapy, individual therapy. I mean, it's evidence-based. A lot of cognitive behavioral therapy is typically the base of most IOPs. Usually we teach DBT skills in them. There's a ton of motivational interviewing because we are working with ambivalence often. The patient population that I work with currently, I get a lot of people that have legal involvement. So there's often a lot of pre-contemplation or ambivalence about being at IOP at all because they're typically like court-ordered to be here. So I use a lot of motivational interviewing in my pretty much every single day. It's just kind of my jam. There's 12-step integration most often, unless the program uses a different base or core. Most IOP programs do random alcohol and drug testing. Some of them do not. If that's something that like the person really wants, is that accountability from random drug and alcohol testing, that's definitely something I would ask because there are IOP programs out there that do not do the testing. I do here. I try to, once every 1.5 weeks, make sure that somebody is being tested just because I feel like it adds a level of accountability for them. Plus, like I said, I do a lot of work with the courts. So just having that additional, they say their sobriety date is such and such, and the drug screens are confirming that. In IOP, we do a ton of case management as well. Like I said, I'm the only person here, so I am also their case manager as well as their therapist and their group facilitator. So I'm kind of everyone here. Bigger agencies will have probably a case manager on staff to help with that stuff. And obviously, since it's substance use treatment, there's a ton of relapse prevention that's wrapped into the program. So this is like my schedule that I use. Other IOPs are free to write their own schedules, their own lectures. Some places buy curriculum and use that curriculum. Some places make their own curriculum. It just really depends on what the agency wants to do and how they want to do it. And so a day in IOP for us is that people will show up at 6 o'clock. I go over the group rules, expectations, those types of things. It's in a group setting. So, usually there's anywhere from 6 to 14 people. It just kind of depends on the season and the time of the year. Like right now is as school is going back into session, we see a large uptick in people entering treatment. So my group right now, I think I had 12 the other day in group. So it gets kind of big, and then people graduate and the new people come in. I run a like open group, so people are always completing and always joining the group as it goes. Um, we have them do introductions, like quick introductions, like my name is so and so. I usually have them do a sobriety update right away at the beginning of group, because the worst thing for a person who has relapsed is to sit on it for an hour and a half or 2 hours before they get to, tell people that they relapse. It just creates so much anxiety in them. So I give them an opportunity to share, what your sobriety date is, any quick life updates. Now, so we're seeing people pretty much every other day. So there's not a ton that's happening in between our visits typically. Usually it's like, well, I went to work and I took my kids to school. Is usually their updates, because usually not too much is happening from day to day. So kind of a quick life update, they do that. I'll roll into a lecture. And other places call it other things like workshop, or they have nicer names for it. I just call it lecture. But it really is like I introduce a topic. I get a ton of group participation from them as we talk about the topic. And I kind of educate them, teach them skills. We'll do like actual practice of the skills, all of those kinds of things. So, I have a 22 lessons in my lecture series because my IOP is about 18 sessions long. Um, I also have recovery speakers come in, so that, adds some more spaces in there. And sometimes the lecture will take 2 sessions to complete as opposed to one, because like the group involvement's so strong. Um, so I'm pretty flexible in how it goes, but this is the general outline that I follow, so that people can learn about these things. And then if the patients are like, if the group is really interested in something, then I can throw in a new topic for the following session. If like we're doing, anger, and there's a lot of discussion on fair fighting, in relationships, I can bring in a fair fighting lecture to follow that up and kind of help drive home the ideas and the skills, and help create that insight with them. So I have like, I don't know, I have a folder with like 100 different topics, so I can usually just pull one out and use it if I need to. Um, but yeah, we cover everything from grief to how addiction changes the brain, to anger, trauma, um, mental health. Um, I think my favorite one is the what price am I willing to pay? It's like a cost and benefit analysis. That one is always like, patients love that one because it puts it in black and white for them, the costs and the benefits of addiction. So that one is really good. They usually take a quick break then, because I will say that the majority of my patients use nicotine in some form, which is a thing. If we can figure out how to get them to stop doing that as well when they stop using, that would be amazing. Because good gravy. And then we will do an activity where we practice some kind of skill that goes with the topic. And then we'll kind of talk about that a little bit, what that experience was like for them. Because for a lot of people to like practice a coping skill, it is super weird. It's super strange for them. It's outside of anything they've ever done. So getting some like real life practice in that stuff is important for them. It may encourage them to do it in their, normal everyday life. And then because my building is really, really small, I have to send them on break again so I can move all the tables out of the way and make a circle with the chairs. And then we'll start group therapy. And that is really driven more towards not so much as like a check-in, more towards what are you working on? What do you need help with today? And using the group members as support for what they're going through in their life currently. And then I have like a checkout worksheet that I have them do where they kind of list the goals that they're working on, what they learned today, just something where they can kind of reflect internally. If we have any graduations, we'll do those. And then we end group and they all go home and they do their lives for the next day and a half. And then they come back and we do it all over again. So it is really good. The group usually becomes really cohesive. They generally really start to support each other. Um, Oftentimes you'll have a group go through where like you're like these guys they're just amazing. They are doing this, they're truly motivated, they want this. Um, they end up like inviting each other to go to AA meetings together or NA meetings or Celebrate Recovery or whatever they're going to. And they end up doing those, building like those healthy bonds in recovery, where they have people who understand what they're going through. All right, I've seen some questions come in. Is there a list of these programs? I have a rough list. I may be able to put a better one together. And I could send it out to Will if he is okay with that, and he can send it out to you guys. DHHS does not provide SUD services, however, they often refer to community agencies that do. Yes, DHHS does like the LOA program for many SUD programs. And so they work with outside agencies. I do not understand the referral process regarding IOP. How does one get an IOP? How do we get someone into IOP? I'm going to go over that in 1 second, so I'll cover that in a little bit on how we can refer into it. I have a whole slide on that, so I'll get to that one in a second. Any like questions about what IOP is as like a program? Look at that, I taught that so well. So yeah, so IOP is basically, it is outpatient treatment where people get to live at home, get to live in the sober living house or wherever they're living. And they get to go to treatment a few times a week, and they get to learn and they get to build relationships with others in recovery, and they get therapy. And so it really starts to lead them on the right track and get them on the road to sobriety, essentially. So I was thinking like, how do I get into the referring idea? And I was thinking, what questions should someone ask if they were going to be recommending that somebody do IOP? So IOP, for a person to be like appropriate for IOP, we really want them to be medically stable. So a low risk of withdrawal is typically what I'm looking for. If with alcohol use, alcohol withdrawal is dangerous, very dangerous for people. So making sure that if they're going to be quitting drinking, that it is safe for them to do so. Like, do they need to go to a detox facility to withdraw? They did open a new like detox only facility in Omaha. It's called Redstone, and they just do detox, and then they work to get them into treatment centers outside after that detox. So if you ever need anyone to go to just detox, they're pretty cool. That is a really cool thing. And so making sure that the person is like medically stable and medically safe. Can they safely participate? I think about like mental health wise as well. If someone's like in active psychosis, it can be hard for them to be in a group. Also, so making sure that like mentally they're stable as well, that medically they're stable. Sometimes addiction and alcoholism, it does a lot of damage to the body. So there can be a lot of medical problems, making sure that they're medically safe, and that they don't need like the 24 care that, a residential center or a hospital could give someone, because they're not going to be with us all the time. The home environment is probably one of the things I like to look at the most when I'm thinking about outpatient treatment is like, are they just going to be going home to a house where everyone in it is using and drinking? Because the reality is it's going to be really, really hard to stay sober in an environment like that. Or are they homeless? Uh, it's pretty hard to do anything when you're homeless other than find a place to sleep that night. So thinking about like, is their home safe? And then like we talked about before, are they willing to participate? Is this something that they want to do? Um, and is this something that they are even interested in? A lot of times I will get people who have been referred to me and they don't even know, what they want or how they want to do it. And I'm like, well, just why don't you just come in, we'll sit down, we'll talk, and we'll discuss things and we can figure out from there what is best for you. And then, after, 15, 20 minutes, sometimes an hour of talking, we'll have figured out kind of a plan for them, of how they want to approach this. But like we talked about before, sometimes people don't really want to or see that they have a problem until they've had some of those negative consequences. So sometimes if I can get someone in the office who hasn't had a lot of negative consequences, just sitting down and being able to talk with them, because even though they're not like, oh, I haven't been arrested, I haven't got a DUI, I guarantee you there has been negative consequences. Like maybe they were texting someone when they were drunk and they sent some texts that caused some problems in their relationship. Maybe it's interfering with their work. Maybe they're waking up hungover. Um, so looking at those kinds of things. One of the things that I often see is like they say like I'm a high functioning alcoholic. But like their hand is shaking so they can't write their signature. So those are just kind of things that like I try to like pull out as well, is that it's not always like the big negative consequences. Like, have you been arguing with your parents about it? Is that something that's been interfering in your life? And then can they attend the 9 hours weekly is something to think about with IOP. Transportation is often a barrier. Like Nebraska is a pretty rural state. So are they able to get where the IOP needs to be? Do they have a car? Like Fremont has a lot of really small towns that surround it. So if I had someone in Oakland who didn't have a vehicle, the reality of them getting here 3 times a week is probably pretty low. So they do have online IOP programs that are offered through like Zoom or other telehealth formats. And that allows people to do it a little bit easier in the rural communities. I do not do a Zoom format of IOP. I only do it in person. I I think there's a new one too. I can't remember the name of it. That's like becoming a nationwide IOP program that's done over Zoom. So that's pretty cool. IOP is always good as a step down after residential as well, or after PHP. It's typically like a natural transition down for them. And yeah, ability to tolerate cravings is also something that I kind of look at a little bit. And are they going to be able to abstain for, a period of time? If we can get them in, it's typically easier to keep them sober than to get them sober in IOP is how I usually describe it. IOP is really good at helping people stay sober. It's a little bit harder for us to get sober in IOP just because they're not with us every single day. So that's another thing that I look at as well. However, I have had people that the first day of IOP is their first day of sobriety. So it really depends on the person as well. But I always think like getting them in the doors with a treatment center, that is the idea, right? Because if what we're doing in IOP isn't working, if they're not able to stay sober in IOP, I can at least then refer them to, the appropriate treatment center. And they might be more willing to do it because they've already built this like buy-in by being in IOP. Things that would make a person, we wouldn't probably want to refer them to IOP. If they're in active withdrawal, obviously, because withdrawal can be so dangerous, we would want to get them to the right place to withdraw. If they're suicidal, they probably need to be on a psych unit. Psychosis, group therapy is really, really hard with someone in active psychosis. I've had it happen a couple times. And we'll make it work, right? But it is a lot more difficult for people in active psychosis. But if it's someone that it's like ongoing, like this is the best their baseline's going to get, we're going to do it. We're going to make it work. And then once again, if they're unable to remain abstinent safely, sometimes we have situations where a person's like, I want to quit drinking, but then they start using another substance to quit drinking. That's not usually super effective because then you end up just being on alcohol and another substance. Or if they have something going on where they need 24-hour supervision. Those are things that we're not able to do in IOP. We're not available 24 hours. I can't even answer my phone between the hours of 6 and 9 because I'm in group. So if it's someone that needs like that 24-hour attention, that's not something that we're able to do in IOP. So the difference between IOP and residential is an IOP, they live at home, a residential, they live in a facility. The amount of treatment and therapy per hour is obviously different. For IOP, they typically need to be medically stable. For IOP, they can maintain going to work. They don't have to like take a leave of absence or anything from their job. Or if they're in school, I get a lot of college students as well. And then the home environment is another thing that I look at, is that their home environment is supportive of recovery. It doesn't need to be perfect, but at least be supportive of their recovery. So not everyone needs residential treatment, which is what often people think of whenever they think of treatment. They think of that 30-day stay. And so I always just think if we can start to push people into just getting into a place and talking to someone. I mean, those of us in this field, we work every day with people. I usually in 15 minutes can usually decide if, IOP is appropriate for a person or if I need to work with them to get them into a residential treatment center. It's kind of, I mean, every single day, this is what we're doing. So we get pretty good at it. I also believe like working with a person, meeting them where they're at is really, really important. I'm telling you what, ChatGPT is really cool because they made this for me. I said, could you make like a outline of when you should recommend to? And I told him, say yes here, say no here. And it was really cool. And then it even let me change it and adapt it. I was like, this is the neatest thing I've ever seen in my life. So if this is just kind of the outline, the most important thing is to address for withdrawal risk. We want to keep a person safe. I cannot withdraw a person in outpatient. I don't have the capability. I don't have the medications. I don't have beds. I don't have anything here. So making sure that they are safe detox wise. If they're safe detox wise, you could probably refer them to an outpatient center. And then if, they're unable to stay sober or whatnot, they could move into a residential treatment center. But that's kind of the idea. I always think like the most important thing is making sure that people are safe in an outpatient setting. And I'm running out of time. Okay, so we'll go back to Michael. Would you guys refer Michael to nothing, to an outpatient center, to residential treatment? What do you guys think you would do with him?
And again, yeah, feel free to drop your thoughts in the
Yeah.
chat.
Oh,
Um,
send Michael to IOP if he
yeah.
would go. I agree. Yeah, I would send him to an outpatient facility, even if maybe he's not willing to do an IOP program. Most outpatient facilities offer individual therapy as well. So maybe they can start to build that rapport with a therapist, or a substance use counselor. And if he ended up, if things continued to progress, then he could do an IOP program. I definitely would send him towards an outpatient substance use treatment center, because there's definitely something going on, right? Like it's progressing, it's getting worse. And I think that's kind of what we look for. Are things getting worse? And if they are, let's get them somewhere. And I think a lot of times we get stuck on like, are we sending them to the right place? Are we sending them to this? I think often it get him somewhere, get him with someone that can help direct him in the right direction, that can help get him where he needs to be. So just getting him to a treatment center gets them kind of in the system so that then it's easier to move to a different level of care if needed. Um, and then questions we had, most places
Yeah,
require a person. Oh, go ahead.
I was just gonna say, I think, yeah, maybe we could kind of summarize the questions on generally around like how do you get someone into an IOP? Is there an
Yep.
authorization, referral process? I think that kind
Yep.
of um,
Absolutely.
summarizes most of the questions in the chat.
Yeah. Yeah. So, for IOP, most places do not require a substance use evaluation. So you literally can just have the patient call the place that you decide to send them to and set up an appointment. Most often it can be a consultation appointment where they sit down and they meet with someone. A lot of places that are like bigger agencies, like your Valley Hopes and your North Points, they'll do a consultation over the phone and help, determine if they're appropriate for outpatient. Um, and I usually will just have them come in and sit down with me and we'll talk, we'll meet. If IOP is appropriate, I will set up an intake appointment. At the intake appointment, I'll get their background and stuff so that I can submit a pre-authorization for IOP because pre-authorization is required for just about every single insurance company except for Blue Cross Blue Shield. They auto pre-auth it, which is wild because it's Blue Cross Blue Shield, so you think they would, but require a pre-auth. But so then I sit down with them, I do a assessment, get their ASAM done, get their background, get their initial treatment plan made, and send off their pre-auth. If had somebody call today, I could probably get them in, what day of the week is say Friday. I could probably get them in on Monday for the consultation. We'd talk. and then set up an intake appointment for, the next day or two. And then right after that intake appointment, they could probably start the next session. So it usually takes, a few days to get into IOP. So I usually say, give it, if they can stay sober through the time that it takes to get into an IOP, they're probably going to be appropriate for IOP. Um, so yeah, I mean, referral to an outpatient clinic is as simple as them making the phone call and calling the place and making an appointment uh, to set up an intake is as easy as it is. Getting into residential is obviously a little bit more complex, but for an outpatient facility is as simple as them calling and making an appointment.
Kayla, do you know what the cost is if the client not have insurance for IOP?
Um, I mean, that depends upon facility. So mine, I kind of go right with Medicaid rates, because I accept a lot of Medicaid and you can't charge less than you charge Medicaid is the rule. So mine, I charge $120 a session, for 18 sessions. So it's $2,160. But if you go to some of the bigger facilities that don't accept Medicaid, they're commercial insurance only, they could be more expensive. Um, when I left Valley Hope, their IOP program, which is longer, it's a 12-week program, cost $8,000 out of pocket. So that's another thing to consider is, does the place take the person's insurance? If they don't have insurance, what's the out-of-pocket cost? Those kinds of things are also things to consider whenever referring. And you usually can get those answers pretty easy if you just call the place and ask, like, how much do you cost out of pocket? And they know the answer off the top of their head because they do this all day long. IOP is not typically appropriate if a person is managed to remain absent for 60 days or more. I don't know. I've had a lot of people in treatment who have more than 2 months of sobriety in IOP. I have a couple right now that have like 4 months or 6 months. Um, because it's like IOP is really education based as well. So it's pretty appropriate for a lot of people. Now, whenever you're dealing with insurance pre-auth, sometimes that gets a little bit more sticky as far as what they say is appropriate for IOP. Um, Sometimes I've had it approved by insurance up to 4 months without any problem. Um, After 4 months of sobriety, insurance gets a little bit more like maybe they don't need this, maybe they need a lower level of care. Um, I kind of look at, are they struggling in their sobriety? Because people can have 4 months of sobriety and maybe not need IOP, but then there's people who have 4 months of sobriety and they're struggling. Like it's not easy for them to be sober. And so I feel like those people would be appropriate for IOP. Um, but once again, insurance kind of runs our lives. So that is definitely something you always have to think about.
Well,
Okay.
I see we're at the end of our hour here.
Yes.
So, thanks so much, Kayla. That was incredible. That was really great and informative. Appreciate you kind of sharing about your story as well, and being open to sharing that. Um, so I did drop a link in the chat for the evaluation survey. I'll also send out an email with that later if you want to claim a continuing medical education credits for today. We also
Okay.
have, um, I think there might have been a few behavioral health providers on there. We can also get certificates for those. Just complete that evaluation. And I
And
suppose
I'll
we'll
put
have to leave.
my email in the chat. If anybody has any questions, they can email me.
Excellent. All right. Well, thanks again. Yeah, great discussion. A lot of great things in there. And we will hope to see everyone back in a couple of weeks. Have a good
Awesome.
Friday.
Thank you
Thank you.
all.